Good afternoon. I hope you had a great lunch, and welcome to Working Better Together. And greetings from the small town of Squamish, British Columbia. Today we are going to review some barriers that block organizational change with respect to a family-centered approach. We're going to learn about Elliott Jacques' values-based approach and stratified systems theory. And in utilizing Jacques' lens, we're going to observe how the Institute of Families and Safe Relationships, Safe Children initiative can promote better collaboration and thus facilitate a shift in practice. Ultimately, what will motivate us to adapt to a family-centered approach? Well, it needs to be more than just education. We'll need a change process that is values-driven, resourced adequately, and transitioned over a long enough period of time to allow for people to adjust to the new way of doing things. We'll need competent leaders capable of promoting organizational structures that promote positive relationships with employees, clients, and families. We're going to need positive opportunities to learn how to understand and value the other person's perspective, terminology, roles, and being able to appreciate the environment of each other. These are the things that we will need, and that will help us to work better together. So now you've had the punchline. In British Columbia, we've had a major problem in identifying extremely vulnerable families and trying to provide an integrated continuum of care for families where there is a triangle of troubles, that being substance abuse, mental illness, and intimate partner violence. These are the two reports from our Office of our Provincial Representative for Child and Youth that highlighted how our client-centered approach contributed to the deaths of these children and youth, and how she recommended that we transition to a family-centered approach. And this is me, wondering, how is it that myself and others, other disciplines who come to this with so many different lenses, both different lenses of our own, but different lenses because we've had different training from different professional backgrounds when it comes to work with families and work with clients, how is it that our organization and our province is actually going to help unify us so that we're looking through the same lens? And my central question as I pursued this became, how do we help mental health professionals make an ideological shift in practice and shift from a client-centered approach to that of a family-centered approach? The elephant in the room for us is family-centered care. All of us have slightly different ways of approaching the same subject. No one person, family, or discipline has the whole picture. I know that my employer, which is a health authority, Vancouver Coastal Health, appreciates this, and I anticipated that they would most likely help mental health staff adapt by providing education and training in the way that they normally do when there's a new approach or a new model. And I wondered, though, if education alone was actually going to be enough. So thank you today for the opportunity to talk with you about how we might overcome barriers that impede collaboration and get in the way of us working toward a family-centered approach. And the lens through which I started to look for an answer. Well, I have a hero, and he's a person who's really keen. He's a theoretician who really understands organizational dynamics. And I don't know if you'll have heard of him, but you will know something about him. My hero, Dr. Elliott Jacques, he is the creator of trust-based social systems and stratified systems theory. Now, you might not recognize his face. You might not recognize his name or his major theoretical constructs, but I'll bet everyone in this room knows something about him. And especially for the woman who just came in, if you're comfortable, there's room up front if you like. I don't want you to have to stand up if you don't want to.
Okay, I'm good to stand for now. Thank you.
Okay, thank you. Who here has heard of the term midlife crisis? Yes, well, this was the creator. So Dr. Jacques was a fascinating man. He was a physician, and he became a psychoanalyst, and he was encouraged and invited, actually during World War II, to go to England and help them with their military and how they were facilitating their military as a business and helping them so that they could have a more efficient service. And that was fairly early on in his career. As his career moved along, he was very keen as a psychoanalyst to wonder about how it is as individuals, how can we be most creative in our places of work, our places of employment, and how is it that we function as groups? And then within these groups, how is it that an organization can help us to work to our fullest potential? So these were his central questions. And he was in an era where things were very much quantifiable, and he was very keen to have things be measurable, observable, and reportable. He recommended and explored our understanding of human nature and trustworthy social systems in order to create effective working environments capable of achieving organizational goals and providing rich opportunity for the expression of human capability, creativity, and satisfaction in work. He wrote that an organization needs to treat its employees well, and employees in return are expected to behave with integrity, commitment, reliability, initiative, and cooperation. The structure and the leaders need to provide a trustworthy working environment, one that fosters healthy relationships and positive social interactions. To have people in roles that suit their skill levels. So here employees are energetic and effective, and as you go up the line from entry level to executives, the worker's ability to abstract and think along increasing time spans becomes more and more sophisticated. So he really was a proponent that employers needed to really know their employees and have people to be suited to their positions so they weren't overemployed or underemployed. He felt that organizations needed to be value and behavior congruent, and only then would employees be able to adapt to change, and only then would organizational goals be consistently met over the long term. So Jacques would promote collaboration through shared values and purpose, mutual respect, integrity and trustworthiness, competency in one's roles, competent leadership, adequate time, resources, continuous quality feedback, overcoming cultural and systemic barriers within the organization. So Dr. Jacques would tell us that if you want to have a shift in practice, you need to organizationally have both process change and culture change. So what does get in the way of mental health care providers adapting to a family-centered approach? Have you ever worked alongside colleagues when there was an organizational shift or change or new policy, new way of practice, and you would listen to your colleagues and some of them just did not want to? Have you ever thought about, gee, it seems to me that this organization, the direction they want to go, let's say, for example, family-centered approach, that you were behind that. You thought that this was a great concept, and you couldn't quite understand why it was that your colleagues, at least some of them, were so resistant to change. Have you ever wondered about that? Because it seemed like it was going to be a good direction. Well, why is it that people hesitate? Well, Schuler writes of 10 reasons why people resist change. You have these in your handout. So today, because we're short of time, I'm just going to highlight a few of those for you. So there may be an absence of role models to demonstrate the new activity. People fear they lack the competence to change. People fear hidden agendas among would-be reformers. And 10, they believe the proposed change is simply a bad idea. Quite frankly, they think it stinks. So our colleagues who are resistant to change initially may have very good reasons, and it may not just be because they are wanting to be difficult. So next I turn to implementation science. And implementation science asks this really key question. It asks, what is it that motivates employees or workers to adapt to organizational change? And I came across a fantastic study. I'm thrilled with this study, and I'm just so happy to share it with you. It's fairly hot off the press from 2013. This is a national American study by Rangachari Rissing and Rethmeyer. I hope I'm pronouncing the names correctly. So this is a story about a central line bundle or a central venous catheterization. And this is such a quintessentially good study for this because it talks about implementation success and failure, and it's so concrete. Variables are easily observable, measurable, and recordable, whereas in my field, mental health, well, those variables less so. So in this example, the ability to follow hygienic best practices was literally a matter of life and death. So they can tell when they're getting it right and when they're getting it wrong. Many healthcare organizations try to implement changes through various processes of education and training, especially in medical settings where decisions and actions can have life or death consequences. It is thought that simple awareness of evidence-based guidelines and mandated organizational policy will be enough to encourage or motivate medical staff to do the procedure correctly. So inserting a central venous catheter into a large vein in the chest, neck, or groin, in the use of administering medications, fluids, obtaining of blood, measurement of central venous pressure is a procedure that, if done correctly, can help to save lives. However, if it's not done correctly, it can introduce bacteria into the bloodstream, which then leads to infection or sepsis and possible death. So if you get it wrong, the patient will die 25% of the time. And we certainly know, well, I don't know if anybody wants to get it wrong. So what were the evidence-based practices? Well, there are 5 of them. The first 4 that you have before you are strictly to do with hygiene. So when they put in this medical device, the nurses or the medical practitioners must follow these 5 steps 100% of the time, 100% accurately. If you mix up something, if something goes wrong somewhere around step 3, you are supposed to start all over at step 1. Can't make any mistakes. You need 100% accuracy 100% of the time, or remember, you're going to kill 1 in 4 patients. Number 5, and this is a key one for us to remember today, has to do with, ideally what would happen is the doctor and the nurse would have a discussion every day about this medical device. And they would ask the question, is there any way possibly that we can remove that device because you're at such high risk for developing infection? Inserting it, but also having it in. So every day, it's really important that the doctor and nurse have that discussion. So, across the US, they are having a high risk of, it was very different floors within different hospitals. Different hospitals were having different rates of success and failure. And they were asking, the researchers asked this really key question. They realized that there was a dilemma between what was known, because they know with these 5 best practices, if you follow them, things are going to be fine. Get it wrong, you're going to hurt somebody very seriously. So they wanted to know, what's the difference then? Why is it people know what to do it properly? So why are they getting it wrong? Like, what's getting in the way? So what's actually being done? What are the barriers? And I was so pleased. Here, Rangachari and his colleagues asked a question that Jacques would have asked. They asked, what are the cultural and social barriers that are getting in the way of staff doing what they know to be the right thing? And could it be hospital culture and poor communication? Yes, it was. So I'm just going to give you the highlights from that study, and the findings were that they needed to acknowledge that there was no one single intervention in and of itself that was effective enough to bring down the hospital incurred infection rates. And they discovered that education in and of itself was just simply not enough. So I'm going to just highlight for you today what were some of the things that actually tipped the scale so that they're now having fewer hospital incurred infection rates because of this. The results aren't finally in, but they are having some successes. The study is ongoing. So there were some primary things that made a difference. They had emergence of promotions or promotion of champions. These were frontline role models. Think of them as the canaries in the coal mine, the ones who are your early adapters. They can catch when something's not going right, and they can understand why it's not going right, and they can verbalize that. And they were able to talk to their leaders and their bosses about things that were actually, what was actually being done in the field, where it was going wrong, what were the everyday things that were just getting in the way. And they were able to suggest process improvements to their employer. And here was something that was pretty significant. Leadership actually listened to them and followed through and remedied the problems. Next, do you remember item number 5? How you have to have that? Who here has worked in a hospital? Inherently, is there not dynamic tensions between nurses and doctors? There's a hierarchy, it's just the nature of the work. Well, in the past they would find that because of this inherent dynamic tension, sometimes nurses and doctors would avoid having those key conversations. So what the researchers here did was they started to create things within the environment through quality of communication logs, processes to track the conversations, and they actually helped to make these conversations between the doctors and nurses more socially reinforcing. So they stopped avoiding it, and they started to have more of them. They counted them as less days with the devices in overall, and that helped. And third, they had clinical educators who had weekly values-related dialogue. This is non-judgmental, non-critical dialogue with staff about their feelings and successes and challenges in implementing the practice. So if a nurse admitted to doing something wrong, you know what? A code blue was over there, I dropped the device, I knew I was supposed to start at 1, I knew we were short-staffed, I knew I was choosing to help, how am I gonna save the life over here, but take the risk here? Well, I took the risk here. And instead of being criticized for that, the administration listened and tried to remedy some of those difficulties. And of course, for the next year, they had more ongoing education. So I thought, wouldn't it be wise to apply Jacques' guiding principles in order to optimize successful implementation of a family-centered approach? And I started looking for what Jacques would call a requisite organization. Well, unfortunately, I wasn't able to find any perfect fit. But I was able to find some worthwhile programs, organizational strategies, and initiatives happening in our province and in my small town and in the corridor in which I work. And I'd like to share just 2 of those with you today. The Canadian the National Institute of Families is an example of a family-driven organization influencing broader systems and organizations. Since 2009, this organization has been connecting children, youth, and families, healthcare providers, educators, researchers, policymakers, and businesses to better address the mental health needs of Canadian families. Now, the key here too is a values-based approach which promotes healthy, pro-social interactions. Think item number 5. And within this institute, they have trademarked a concept. It's a practice and endorsement all rolled into one. It's intended to help families and those working with them in communities and across systems to identify and act upon what is meaningful and what works to improve mental health of infants, children, youth, and their families. And just next weekend in Vancouver, they will have their annual conference, and young people, families, and service providers will be able to contribute to the design, the content, the delivery, and evaluation of this trademark concept. So then, one of the ways this values-based approach could assist to unify us is with the development of guiding principles and accountabilities of practices for services and organizations providing family-centered mental health care, so that at some point in the future, organizations could opt to become Family Smart approved. Safe Relationships, Safe Children is a multi-ministry provincial initiative that stemmed from the representative child and youth reports, the 2 that I highlighted earlier in the presentation. And they combine both community development processes and family, community, and staff education, and organizational policy and multi-ministry protocol agreements. So the process utilizes champions and promotes positive social interaction. And it reflects competency and roles. Remember, Jacques talked about suitability of you, the level that you were working at? So how does this process occur? Well, we start with local steering committees that are made up of stakeholders and family members. These report to a provincial steering committee, And where are we at? So in phase one, what they did was they researched the issue and they sought feedback from family members about gaps in service. And this is one of the ways that they researched that was through a family journey mapping exercise. And here you can see a family was interviewed and over a span of years, they had access to a number of services. So these would be a family where I talked to you about the triangle of troubles. They would have had at least 2 of those 3 aspects of difficulty. And now it's years later, the family is doing quite well, they're in a stable place, and they're asked to reflect back. What was it like when you were dealing with the frontline staff? What was it like when you dealt with that organization? What helped? What was a barrier for you? And then that feedback is then provided to research and education for frontline staff and care providers and other people who will be coming in contact with the family. And so it's also geographic specific. And they also developed a toolkit and guide to enhanced practice. So think of this as a recipe book for your community development project. And so what they do is they develop this, they practice it in phase 1, and then in phase 2, which is where we're at now, instead of it being in a rural and urban area in the province, we're actually now doing it in 22 different communities. And project managers function as champions. And here there are opportunities for local steering committees to apply the community development processes and tools developed and to provide feedback again to the provincial steering committee about how these tools are working, so they get a dress rehearsal. And this gives us a chance to sort of iron out the kinks or iron out the wrinkles so that in phase 3, those other communities get a really well developed, really well rehearsed package. So, what components of values-based stratified systems theory does this initiative contain? Well, it encourages lots of opportunities for multiple agencies and family members to work together over a united values-driven cause. There's shared educational experiences. It enhances positive communication experiences amongst a broad range of community members. There is competent, respectful leadership. There are opportunities for constant feedback. There's a policy component. So in Vancouver Coastal Health, we now have a family involvement policy. I'm not going to show it to you today, it's just words on a page, but what I can tell you, I really like this policy. And one of the things I really like about it is because it defines family as an intentional family. Who's important to you, that's your family. So it's quite progressive. And family advisory committees were very active in the development of it. Secondarily, there's a policy component, there's a protocol agreement. So earlier on, I've heard a lot of people talking last night and today about how is it that we're going to get different organizations to cooperate and work together. Well, in the past, we really haven't had tools for that. So we are doing it not through legislation changes in BC, we are actually doing it through protocol agreements. So these would be, think of them as kind of multiple umbilical cords that are bridging or linking different ministries and organizations. It clarifies roles and activities of the frontline workers and their managers, and it promotes collaboration and cooperation. So what you have here before you is a Vancouver Coastal Health Protocol Agreement that already exists. It's for moms who are having at-risk babies, bringing them home to at-risk families. And this is being used as a template for a protocol agreement for our families where there is a triangle of troubles. And the most important part of this, for me as a frontline worker, is this part at the end where there's signatures of delegates of various ministries. So at times when we have families who are multi-problemed and in a lot of distress, and they may not want to give us permission to collaborate with each other from different agencies and services, but they need us to, this is the legal mechanism that permits us to do this. So here's what we've learned today. Mandates, policies, and clinical education are just simply not enough to shape ideology or promote long-term systemic change in cultural practice. If we are to provide a longer-term, well-resourced, values-driven approach, one that includes families, frontline staff, managers, and other specific organizational leaders, I think we could successfully change from a client-centered approach to that of a family-centered approach. And in this way, we will be able to work better together. So thank you for your attention today, and thank you for your time. Any questions?
So we have about 5 minutes for answer questions or comments.
It was that good, eh? Yes.
I'm a physician, I'm a psychiatrist, but I was a general doctor and a pediatrician for a long time. The issue of hierarchy that you mentioned,
Yes.
versus doctors, is certainly significant. But I must say the difference between the relative simplicity of what you describe and the barrier and what you're talking about here makes the difference seem overwhelming.
I would agree. The way I've presented it is very simplistic because of time limitations. I understand it. It's a very complex issue. And that's one of the things I like about Dr. Jacques, is he was able to really appreciate those organizational dynamics that are the reality that we need to deal with. And none of this is simple.
Well, but for example, you talked having a meeting with hospital staff
Yes.
to discuss, so you facilitate the relationship between nurses and physicians. That's hardly enough, because that would be so intractable and involved over a long period of time, especially, for example, physicians, depending on where you are, they're reluctant to give up authority and power to nurses, as nurses, particularly in hospital settings, develop more skills than many doctors have, in particular issues like inserting an IV catheter. So that is something that it seems to me it would take more than a conversation to
Yes.
deal with. How do you do it? So what do you actually do within the group settings that you have with the agencies which are entrenched and have not only value and hierarchy differences, they also have differences in their worry about loss of resources, employment, funding, skills. How do you attempt to implement that?
Well, I agree with you. It takes a long time, and it is very much process-oriented. What the researchers here did was they did a number of variables. They did a number of components. So they had a campaign called a Take It Out campaign, in which they had champions who were physicians as well as nurses who would promote that campaign. They had journals, communication journals, so that every time that there had something to do with these central venous devices, they had to track and monitor it. And these in turn were monitored every single day. And then they also had to do it over a longer period of time. So the physicians and the nurses were basically starting to be reinforced as a team, as units, as teams themselves.
Let me rephrase it, but what did you do in the more complicated situation?
Right. Well, unfortunately, I'm mostly a frontline worker, so I don't quite have control over that, but I can tell you that what I do for myself is I look for psychiatrists and physicians that I can build relationships with over a long term. And we have those kind of discussions and dialogues. And I ask them, how can I be of assistance to them? How can I help them to get their job done more effectively, more efficiently? So I think that Elliott Jacques would not have this language. He did not have this term that he used, but nowadays we refer to it as emotional intelligence. So that's, I hope that that is a little bit of it. But it is very process and relationship oriented, and values, around values discussions. Okay.
So we have about 1 more minute. If there's any other questions or comments?
Okay,
Thank you
thank
so
you
much,
very
Angela.
much.